Thank you. My name is Seena. I'm one of the doctors working as a clinical fellow in Southend University Hospital in the Department of Cardiology under Mid and South Essex NHS Foundation Trust. And my presentation today is about a rare complication of a dual antiplatelet therapy. So this is a case report, and I would like to thank my consultant, who is Dr. Nasri, and my team who worked with me. This case report was also published in one of the PubMed indexed journal. So this is a 65-year-old woman presented to ED with central chest pain or epigastric pain as well. On a pain scale, she scored 10 out of 10, radiating to the back, not relieving with GTN spray. She also had associated symptoms like nausea and an episode of hematemesis. She complained of a bit of shortness of breath as well. Looking at her past medical history, she had a recent STEMI, and she had a stent put in to mid-left circumflex artery 6 months ago, and she was taking dual antiplatelet therapy, which was aspirin and clopidogrel at that time. She had mild aortic regurgitation with normal LV. She had a history of angina, hypertension, and high cholesterolemia. Looking at her family history, she has a strong family history of ischemic heart disease. She's an ex-heavy smoker. She's intolerant to flu cloaks. Otherwise, she's functionally stable, independent, retired, previous medical secretary. Looking at her regular medication, she takes dual antiplatelet, aspirin, and clopidogrel, beta blockers, ACE inhibitors, nitrates, statins, as well as PPI. On examination in ED, her GCS was okay. She looked very unwell and she couldn't lie flat because of her continuous nausea. On abdominal examination, there was no organomegaly. Abdomen was soft and non-tender. There was bowel sounds present. There was no epigastric tenderness. Because she complained of pain radiating to her back, we took blood pressure from left and right arm, which excluded any aortic dissection. Other physical examinations, including respiratory and cardiovascular, were normal. Test results, her ECG showed old T-wave inversions, which was present during her NSTEMI 6 months ago. Her troponin were at her baseline around 25. Hemoglobin, apparently it dropped to 122 from her baseline of 135. Echo was normal with ejection fraction of more than 60%. The ECG here on the left is her new ECG, and on the right is the previous one 6 months ago. There's no new ischemic changes which we could appreciate. On her bloods as well, her hemoglobin has dropped from 122 to 135. Her platelets were normal, her INR was normal as well. Her troponin were at her baseline, her kidney functions were also unremarkable. So at emergency department, she was started initially on IV pantoprazole along with antiemetics because she was having continuous nausea. After a few hours in ED, she had another episode of hematemesis. So the ED doctors held her antiplatelet. She was kept nil by mouth overnight, and it was discussed with gastroenterologist who advised for upper GI endoscopy, which was done next morning. And it showed unusual lumen obliteration, and they said possible hematoma extending up to gastroesophageal junction. You can see the hematoma there, which is really obliterating the lumen. So they discussed it amongst gastroenterologists, and they advised for a triple phase CT, which showed an extensive medium-sized hematoma in the wall of distal 2/3 of esophagus, extending up to the cardiac end of stomach, but not involving the rest of the stomach. And there was no active bleeding noted in the arterial phase. So after that, she was discussed at the MDT meeting again, including gastroenterologist, cardiologist, and other team members. They decided to treat her conservatively. They've admitted her and given her IV proton pump inhibitors. Her clopidogrel was stopped and advised to continue with aspirin to balance the risk of stent thrombosis. After 72 hours, her symptoms completely resolved and she was safely discharged home. She was asked to follow up in 2 months' time in outpatient clinic when she had a repeat gastroscopy, which showed complete resolution of the hematoma. For discussion, spontaneous esophageal hematoma is very rare. In literature, it's only less than 100 cases reported. It can mimic acute coronary syndrome, aortic dissection, Boerhaave syndrome, etc. So it's very important to keep our differentials open when we see such a patient. And most of the cases reported were, like ladies above 50 years of age with cardiac background or high-risk patient. In this case, the risk factors of this patient were dual antiplatelet therapy and a recent PCI following NSTEMI. She also had vomiting, which probably led to the hematoma, and possible esophageal fragility relating to any reflux. So in this case, the diagnostic test that confirmed the hematoma was endoscopy and the contrast-enhanced triple-phase CT. No, typically, it's spontaneous hematomas are non-perforating, presents with retrosternal chest pain, dysphagia, odonophagia, or hematemesis. Diagnosis can be either by upper gastric endoscopy or contrast-enhanced CT. Most of the time, it's managed conservatively by holding one of the antiplatelets, but it's very important to discuss and consider the risk and benefits when we hold the antiplatelets if the patient has a cardiac history or high-risk factors. In conclusion, again, the take-home message would be we should keep an open mind for differentials when we see such a patient. It can be a misdiagnosis of peptic ulcer disease, upper GI bleed, or an ACS because of the presentation of chest pain and high-risk factors, ex-smoker, recent stenting. So we might even think about a stent thrombosis. So it's very important to keep a very wide open differentials. Most of the cases, conservative management is more than efficient. Also, as we said, multidisciplinary team meeting is very crucial for best outcomes. And we should reassess the antiplatelet therapy based on risks and benefits. So that was a learning point for us as well. So thank you for your attention. That's it. Any questions? Okay, thank you.